So good evening to you all, and good day, good morning to everyone joining us from different parts of the world. My name is FIHIMN from Rwanda. I serve as committee member within TOG Global Education and Training Committee. On behalf of the Operating Room Global and the TOG Global Education and Training Committee, I'm delighted to welcome you to today's global webinar. We are pleased to have you all with multidisciplinary audience today, including surgeon anesthesia providers, nurses, surgical technologists, professionalists, educators, researchers, students, and healthcare leaders. We are currently joined with a participant from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, Middle East, and Americans, or elsewhere, you are most welcome. Good morning to those joining early in the day, good afternoon to those in the middle of your day, and good evening to those joining us later. We are grateful to have you all with us. We strongly encourage active participation through the session. Please use the chat box to introduce yourself by sharing your name, professional title, and country. Post your question and comment at any time during the presentation. Our moderator team will be actively monitoring the chat and will bring your question forward during the discussion segment. For those joining talk session for the first time, the Operating Room Global is multidisciplinary professional platform representing over 260,000 surgical and preoperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TOG bring together for two healthcare disciplines and specialty currently, and operate as not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, TOG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, capacity building, with a strong focus on safety, equity, and system strengthening. TOG is international accredited continuous professional development CPD providers recognized by CPD Group, underscoring the quality and global relevance of our educational activity, and is supported by academic and innovation arm. The Operating Room Global Center for Education and Research, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnership. Our affiliated journal, the Operating Room Journal, is open access, peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that inform practice and policy worldwide. TOG is also proud to host its institutional review board, TOG-IRB, officially registered with the U.S. Office of Human Resource Protection, reinforcing our commitment to ethical, responsible, and global credible research. TOG is driven by voluntary leadership model, powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances including G4 Alliance Intersurgeons and are listed with the Union of International Association and the Global Civil Society database, reflecting our global accountability and reach. Thank you for this webinar. You are mostly welcome with us. Thank you.
Thank you so much, Pacific. Good morning, good afternoon, good evening, everyone. My name is Dr. Insote. I'm also a committee member of the Global Education and Training Committee within TOG. It is with great honor that I introduce our first speaker for this session. Our first speaker is Professor Omokhoa Medicine at the University of Benin and the University of Benin Teaching Hospital, Benin City, Nigeria. Professor Adeleye holds qualifications in medicine, artificial intelligence, public health, health policy and management, international development, and health information management. He is widely recognized for his contributions to public health leadership, bioethics, digital health, and responsible application of artificial intelligence in healthcare. He previously served as a director of the Center for Artificial Intelligence Development at the University of Benin and as deputy chairman of the Medical Advisory Committee for Research and Ethics at the University of Benin Teaching Hospital. At the national level, he serves as a member of the National Bioethics Committee of Nigeria and as chairman of its Technical Working Group on Education. He is also a member of the National Certification Committee for the Eradication of Polio in Nigeria, contributing to national public health policy, ethics, and disease eradication efforts. In addition, Professor Adeleye is a faculty member of the West African Bioethics Training Program in Ibadan, Nigeria, where he supports capacity building in research ethics and bioethics across the region. His work continues to bridge public health, ethics, technology, and innovation, making him a leading voice on the future of artificial intelligence in healthcare and global surgery. Today, we will be speaking on the role of artificial intelligence in global surgery. Please join me in welcoming Professor Omokhoa Adeleye. Thank you, Prof.
Thank you very much. I appreciate you. I was even wondering at the time whether I had all those descriptions in my little self. Thank you very much once more. Would I be allowed to share, please? Can I be enabled to share my slide? Okay. Perhaps we could have someone to control the traffic so we don't have distractions from people who are entering the waiting room. But we have to move regardless of the situation. I want to thank the organizers of this program for the opportunity given to me to do this presentation. I do not take it for granted. I'm quite familiar with the organization. I'm a part of it, I must admit. And I want to enjoin everyone to please keep an open mind as we all flow along in the presentation. 20 minutes or so, I should be through. The topic I've been asked to discuss or present is the role of artificial intelligence in global surgery. And I'm going to approach that will permit discussions and not necessarily providing all the possible information you can have on it. Accordingly, I'd want to just go ahead and show us this brief outline and then move on to introduce the topic. Our objectives are as follows. We want participants to be able to define key terms, know the global surgical care gap, understand AI in surgery, and then to be able to drive global surgery through AI. So what is artificial intelligence? It is defined as systems capable of performing tasks that normally require human intelligence, including learning, reasoning, perception, decision support, and so on and so forth. Through machine learning and deep learning, which are the components, the core components of AI, AI uses computer systems trained on data that engage algorithms to recognize patterns and perform tasks. Now, global surgery is a relatively new terminology, which examines issues around study, around research, around practice and advocacy, the objective of which is to improve health outcomes and achieve health equity for all people who need surgical and anesthetic care, with a special emphasis on underserved populations and populations in crisis. Global surgery uses collaborative, cross-sectoral, and transnational approaches, and it's a synthesis of population-based social strategies with individual surgical and anesthetic care. One author has imagined global surgery with these foundations, the pillars, and the roof. And this model sits in well with what we believe in TORG, especially when you look at the foundations. Diversity, equity, and inclusion. Nobody should be denied of access to surgical care just because he is who he is or she is who she is. And the pillars that support global surgery are education and training, governance and infrastructure, then development and research and quality improvement, logistics and surgical service delivery. Overall, we have interdisciplinary collaboration as a roof, because global surgery does not stand alone. It is not a vertical standalone concept. It is in fact multi-sectoral and intersectoral at the same time. Global surgery rests upon the very strong political will of the leaders of a country or a subnational region. But there are gaps, and we're concerned about these. There is a crisis, as we would like to put it. The total surgery gap is 5 billion people who lack timely, safe, and affordable surgery. Poverty is a very major factor in the crisis, and only 6% of surgeries happen in the poorest 1/3 of the world, where 1/3 of global population live. So this clearly points to inequity, exclusion, bias. Annual gap in the low and medium income countries reflect an additional 143 million surgical procedures that define the surgical care gap in these countries per annum. So this shows that we have a huge population globally of people who need surgery but lack access to it. Preventable deaths amount to 18 million out of the 143 million we just talked about. Human resource gap, 2.2 million more surgeons, anesthetists, obstetricians are needed. The economic cost is huge. And the current traditional clinician training paradigms cannot scale quickly enough to meet the demand. AI can act as a force multiplier by amplifying existing surgical teams and skills and optimizing remote clinical diagnostic decision pipelines. Conventional training paradigms, as we said, cannot move fast enough, and AI can only make things better. So how does AI connect with surgery? We'll just quickly go through some examples that will help us appreciate the point. Human oversight, we must emphasize from the outset, is extremely important in AI in surgery. All surgeons are often warned never to see AI in surgery as opportunity to hand over their responsibilities to AI. Surgeons must always take responsibility and provide oversight. So we'll look at 3 dimensions: pre, intra, and post-operative. Just for our attention, we recognize that high-income countries are mostly in the predictive aspect of AI deployment in surgery. That is, that they anticipate complications before they arise. Whereas in low and middle income countries, we are mainly reactive. That is, that we target acute gaps in quality, safety, and access. So that explains why the gap is very wide. This also reflects in the deployment of AI in surgery. Let's look at the pre, intra, and post-operative phases of surgical care so as to appreciate what AI does. So, the critical aspects that we look at when we discuss AI in preoperative care is diagnosis and the planning of an operation. AI-assisted imaging using ultrasound scan, X-rays can identify and flag surgical candidates earlier and prioritize those who need care the most. Adoption, however, is very low. The barriers to AI-based imaging in low and middle-income countries are many. Basically, they include infrastructural gaps, data gaps, human resource gaps, and regulatory gaps. Of course, the financing and sustainability gaps also exist, which is behind most of the earlier mentioned gaps. Intraoperatively, robotic-assisted precision is one of the gains in AI deployment in surgery. AI-enabled real-time computer vision nowadays makes it possible to have AI-enabled real-time computer vision that tracks structures in the body, the instruments used by the surgeon, and then also guides gestures such as suturing gestures during complex, minimally invasive surgical procedures. If you are a part of the professions, you'll appreciate that during minimally invasive procedures, very little movement is required. So excessive movement can lead to damage, and the space is not even there to do that. So AI using computer vision helps to make more visible and more traceable the instruments we use, the structures of the body in order to facilitate the operations. And the implications are that the cognitive strain that a surgeon would have experienced is reduced or alleviated. through supported situational awareness occasioned by real-time computer vision. More precise movements and actions are also executed, and errors are mitigated. Of course, this further implies safety for the patient, and as we shall see soon, early recovery and early discharge. Intraoperatively too, robotic-assisted precision manifests in autonomous camera positioning in the theater. AI models combine tool tracking and kinematics data to auto-adjust the endoscopic view and zoom, freeing the surgeon's attention from the procedure itself. So the surgeon doesn't have to bother about manual adjustment. Measurable outcome gains also happen. We're talking about shorter operating time and fewer intraoperative complications compared to manual techniques. Furthermore, autonomous suturing has also been demonstrated using AI enablement. Researchers demonstrated an AI surgical robot capable of independently sewing surgical stitches using models trained on surgical video and motion data. This illustrates advancement from robotic assistance to robotic autonomy. But as we always warn in this field, surgeons should not take this autonomy for granted and must always bear in mind that despite the sutures and the precision that has been observed so far, especially in Da Vinci Generation 5, that should not be taken for granted. And this is the picture of the Da Vinci platform. So far, 42 countries are known to use it, but they are mostly concentrated in Europe, North America, which includes the US and Canada. Then with limited reach in Africa, South America, and parts of Asia. High upfront and maintenance costs remain the primary barrier to global scale-up. Post-operatively, the Mako robotic arm assisted system improves the precision of component positioning and accuracy of implant placement. We know this can be very, very tedious during orthopedic surgery, especially in knee repairs, hip replacement surgery, and so on and so forth. Implant placement has to be as accurate as possible. Imaging techniques using the Mako robotic arm has become very, very useful. And what is the outcome? Reduction in post-operative pain because there's less tissue invasion. Hospital stay is shortened, and there's improvement in functional outcomes. Post-operative analysis has been a particularly exciting finding in Da Vinci 5, which came out in 2025. Case Insight is an AI-based intraoperative data platform that automatically integrates surgical video, instrument activity metrics, and force measurements. It analyzes recorded procedures and gives the surgeon structured post-operative feedback that enables the surgeon to assess his own technique. He's able to determine or see how much time they spend on a particular aspect of the procedure and then plan to spend a shorter time another time. Where movement was least smooth. Remember that often surgeons go into fine tremor and sometimes coarse tremor of the fingers during surgery. Case Insights also analyzes data on smoothness of the hand and of the instruments the movement made during surgery. Now, there is another component of the Da Vinci 5 technology in terms of post-operative phase data evaluation, which is called the force feedback technology. So along with case insights, robust data is provided that enables objective post-op evaluation of the surgeon's techniques. Again, this is done autonomously. It is already programmed to carry out this evaluation. So the moment the surgery is over, the surgeon has the opportunity to view on the platform his performance. So just to keep in mind, there is gradual advancement from AI assistance to AI autonomy. While this represents an advancement in technology, it must always be borne in mind that the surgeon takes responsibility and never AI. Autonomy should not mean the relinquishing of responsibility for patient safety and care. So robotic autonomy, just for our knowledge, is scaled to the level of 5, from 0 autonomy to full autonomy. So right now, we are able to also demonstrate some level of post-operative phase AI value in Africa. Rwanda exemplifies such a country in Africa, being a low-income country. Machine learning-based post-CS wound infection detection has been shown to be possible in remote health institutions, those health facilities that are too far for the health services to attract a surgeon to come observe, or for the patients to go and see the surgeon in a remote place. Such cases have been well managed using machine learning-based wound infection detection. So what is done? The simple smartphones that we have are used in the process. The smartphone contains the machine learning model. The wound photographs are taken, and then it is determined whether there's an infection or not. And this is because not all levels of health workers can detect early onset of a post-caesarean section infection. Following this closely, we'll appreciate that this has implications for reduction in maternal death. Education, research, and mentoring is also possible using AI. But we'll deal with most of this in the next section that deals with driving global surgery through AI. So our model again shows this. So it means that if we are going to achieve global surgery through AI, then AI should have impact on the components of this model. AI should impact the foundation, that is diversity, equity, inclusion. AI should impact education and training, governance, collaboration, research, quality improvement, logistics, and so on and so forth, including interdisciplinary collaboration and international collaboration. This model is more functional than structural. So we are going to take it as a horizontalizable model where there is integration rather than some kind of vertical dealings. And that's important because many of these things don't stand alone. Collaboration depends on international communication, depends on infrastructure, depends on financing, and so on and so forth. AI technology transfer depends a lot on available human resources that can use this. So because of those interdependency factors, it's important that we look at the framework differently. So, first of all, it's important that in seeking to drive global surgery through AI, regulatory frameworks are required at all levels. Ethical legal frameworks to protect all stakeholders are important. Policies, legal frameworks that do not conflict with one another. Sometimes conflicts exist between one country and another in terms of legal or ethical or policy frameworks. As much as possible, as we go through the paradigm of a global surgical field that must grow together, attention should be paid to all these factors. Integrable policies on AI development in various sectors should be developed, and specific policies that capture global surgery with AI integration are urgently needed. We also need to focus strongly on education and training beyond the paradigms we are familiar with. But there's limited case mix and a few subspecialists at many health facilities in low and middle-income countries, including especially the teaching hospitals. So even those highbrow hospitals don't often have enough. And this can slow down the acquisition of operative skills. But we can start from somewhere. AI-enhanced simulation and feedback tools are helping to close the gap. Simulation-based skills training, recorded case review at scale, AI-powered performance feedback, and distributed mentorship networks, which I have explained briefly here. So physical and virtual models allow trainees to rehearse operative steps and repeatedly before operating on patients. This is, of course, to ensure that skills are acquired without subjecting patients to undue risks. Acceleration of skills has been shown to be possible using these simulations rather than the traditional mode of that takes a longer time under a mentor. Then there's the recorded case review at scale, where analytic tools such as case insights, as we earlier said, allow surgical teams review where movements were least efficient, where techniques were not at their best in terms of speed or in terms of accuracy. So that means the routine cases are turned into opportunities for teaching and learning because they are recorded, the video recordings occur, and because data in terms of graphs and numbers and computations with analysis are there for the early careerists to learn from. AI-powered performance feedback is also a method of collaboration and mentoring. Because real-time feedback occurs, trainees and mentors are able to do a co-assessment using machine learning models trained on the procedures. Distributed mentorship networks using tele-mentoring in telesurgery also comes to play here. International, such as South-South collaboration, is very important here because it provides opportunities for countries to share information and skills so that specialist capacity that do not require high-income countries can be built. Peer-to-peer telementoring and shared platforms can spread expertise faster than waiting for one-directional technology transfer. The 5G network has been integrated with AI, with extended reality, And the emerging systems integrate AI-driven real-time skill assessment and hybrid satellite links to bring high-fidelity mentoring to hospitals that need them most, despite the fact that they have limited network backbone. AI-driven telesurgery telementoring between South Africa and Nepal has shown very interesting results. It's a low-cost arrangement because a simple smartphone video system is used to record cataract surgeries in Nepal and live streamed to a trainer in South Africa for real-time consultation. And it's been rated, the videos have been rated very good to excellent in the streamed cases by majority of viewers, as many as 93%. Research is also key here. Evidence that AI will indeed drive global surgery is currently weak. So it is still a proposal. There is no evidence. You know, in medicine, in surgery, we are very particular about evidence. Is it possible that AI can drive global surgery? Yes, it is possible, but we need to have evidence that it can indeed happen that way, because there are many factors that come to play. So studies are needed to provide this evidence or do otherwise. Such studies should be modeled to suit acceptable methods of learning and skill acquisition, yet one that can be accelerated to catch up with the needs. The studies should preferably be international, following a model that mimics international collaboration for technology transfer of AI application or deployment in global surgery. Other recommendations of how AI can play a major role here will require that we pay attention to some key issues. For example, we need to build locally representative data sets. You know, the computer models, the AI models, ML, DL, all depend on data. Many of the data used to program those machines are from high-income countries. Even where low-income countries, low and middle-income countries contribute to the data are often biased. And so you have biased algorithms, biased partly because most data are from high-income countries, whereas the greatest need is in low and middle-income countries. So it's important that low and middle-income countries develop data management systems towards having or contributing to big data. There's also the need to strengthen digital infrastructure and establish fit-for-context governance. The governance issue here will run through multiple levels. And I want to also emphasize that there is a need to invest in workforce capacity and match AI strategy to context. So in conclusion, we have looked at what AI and global surgery mean, the global surgical care gap, and AI in surgery. We have looked at how we may drive global surgery through AI. And looking ahead, the most promising global surgery applications are simple and low cost. We can start from there. Sustainable progress will depend on infrastructure, a strong political will, representative data, and good governance. It is hoped that these recommendations will be available to all stakeholders to play their respective roles. Thank you very much.
Thank you very much, Professor. It was
I want
indeed
to make a promise here that I'm going to send the submitted copy will have the full scale, the full range of references, both in text and a reference list, so that we can have something more robust. I will also include some readings of fairly recent studies and reviews that have been done internationally that will help us. Thank you very much.
Thank you very much, Professor, for this insightful presentation. Ladies and gentlemen, we'll be having a Q&A session at the end, but for now let's move on towards our next speaker. So, our second speaker is Dr. Hani Bilal, a pediatric surgeon with over 4 years of experience in pediatric surgical care, medical education, research, and global surgery initiatives.
Sorry, I can't seem to hear you. Am I the only one?
Am I audible?
Yes, you are audible.
Yes, you are audible.
Thank you. Okay, so now let's move on towards our second speaker, Dr. Hani Bilal, a pediatric surgeon with over 4 years of experience in pediatric surgical care, medical education, research, and global surgery initiatives across Africa. He currently serves as a pediatric surgery senior specialist in Uganda and holds a clinical doctor of medicine degree in pediatric surgery from the Southern Medical Specialization Board, in addition to a master's degree in health professor's education. Dr. Bilal is also a COS ECSA Associate Fellow and has successfully completed membership examinations with the Royal College of the Surgeons of Edinburgh. Throughout his career, he has actively contributed to surgical capacity building and healthcare delivery through multiple surgical outstretch missions in Sudan and Uganda, helping to expand access to specialist surgical care in underserved communities. Beyond clinical practice, Dr. Bilal is deeply committed to advancing the surgical education and research. He serves as a global research fellow with the Operating Room Global and ambassador for the Search Hub under this Global Surgery Foundation, and is a member of the International Association of Medical Education, which is AMEE. His academic contribution include international conference, presentations, scientific publication, and peer review activities for multiple medical journals. His work continues to bridge pediatric surgery, surgical education, research, and global surgery advocacy, with a particular focus on strengthening surgical systems and improving access to safe surgical care. Today, he will be speaking on the basics of pediatric surgery. So please join me in welcoming Dr. Hani Bilal. Thank you.
Thank you for the introduction. It really humbled me, and I'm happy today, this evening, to join the global audience of the Operating Room Global. It is my pleasure to be here with you, and we will be joining on board together, shipping to the wonderland of pediatric surgery, and I hope everyone is going to enjoy the session. Of course, covering an area, covering a full specialty is not going to be visible in one session, but I try to make it palatable to the audience, and at the end of the session, at the end, every question is welcome. Let's start the meeting. I'm sharing. Okay. I hope now my presentation is visible to the floor.
Yes.
Okay. Welcome again, everyone. And today we are going to speak about the basics of pediatric surgery. We are going to explore some distinct principles particular to the area of pediatric surgery, being proportionally new specialty in surgery, but and fastly evolving specialty. So as we are going in the presentation today, we are going to have an overview, brief introduction about pediatric surgery, and then we are going to discuss and we have a brief overview about anatomical and physiological difference in children and discuss the fragility of children being fragile and require special kind of care along the continuum of the surgical care. Then we discuss the surgical journey of the pediatric patient, the spectrum, some spectrum of pediatric surgical conditions. And then at the end, I would like to speak a little snippets about some particular areas that are particular to the domain of pediatric surgery, having stage surgery and the transition of care, improving the quality of life surgeries. And we will wrap up later with global consideration and challenge facing this specialty worldwide. First of all, when coming to speak about pediatric surgery, we have the classical rhetoric. Always we say children are not simply small adults. So caring for children requires a particular team, required to be taken care of with tender, loving care all through the course of treatment. Because children, of course, they have particular anatomical and physiological and psychological differences from adults. Also, speaking about pediatric surgery, one should consider mentioning Professor William Ladd, which we considered by a lot of scholars in the field of pediatric surgery as being the father of the modern pediatric surgery, as we will see along the presentation, some operations, even synonym to his name, up to date. In pediatric surgery, our trajectory actually is span along a broad area of age group. So treating children as a group are children, but for us, we divide them according to the age group, being a fetus when the child is still in the womb, and neonate for the first months of life, first 4 weeks of life. Then from this first months of life up to 1 year, we call the child an infant, then followed by a toddler, 1 year to 2 or 3 years. Then preschool and school age up to adolescent. This shows clearly that we are dealing with a wide trajectory of age groups with different pathologies and presentation, and of course all this age group have their own distinct surgical condition that the pediatric surgeon has to deal with. Pediatric patients are vulnerable and anatomically and physiologically different from adult patients. Considering this due to immaturity, of course, due to still their organs, still their physiology is still growing. We are dealing with the growing creation. So putting this in blocks and to facilitate and to bring the blocks to the audience, I'm going to speak in systems in brief. So considering the airway and the respiratory system for children, they have distinct airway respiratory system, being still immature, and children are obligate nasal breathers. So and their lung is underdeveloped. All this must be put in consideration when putting this child asleep for anesthesia in surgery, and be adjusted by trained staff, anesthetists. Their cardiovascular system also is still is also distinct from adult. The main thing that for the cardiac output, the heart rate is the main definer, not the stroke volume. So and also they have very narrow window for compensation. This is why they can decompensate rapidly. Regarding the temperature and thermoregulation, children are not like adult. They have a big surface area compared to adult, and also they have less subcutaneous fats, less thermoinsulator, so they are more prone to hypothermia, and this should be considered also in managing the child preoperatively. Children also have their fluid and electrolyte balance. They have high body total water in general. It approached 90% body water content. This is why they are prone to dehydration, and their fluid management should be titrated with caution. Regarding their organ immaturity generally, which will affect the drug dosing, the management of an excretion. So generally, when administering any medication to a child, we should consider this to be the dose in children that is adjusted according to the weight of the child. Generally speaking, children are physiologically and psychologically vulnerable. So as we saw earlier in the previous slides, and this physiological fragility and the organ immaturity represent itself in the rapid decompensation. So children can decompensate very fast, especially in trauma. So they give you like a golden hour or honeymoon period. So you have to act in this limited time before the catastrophic decompensation. And also they have limited reserves. This is why they can't tolerate long fasting, and also the organ immaturity. They have underdeveloped lungs, liver, kidney, and for this, the drug clearance and adjustment of doses should be considered meticulously. The psychological fragility, as we say, always surgery is a trauma, and dealing with these small bodies, you have to consider this with loving tender care all along the hospital course of the child. And of course, children face anxiety and post-traumatic stress, which should be considered in their management. Particular concept in surgery, in pediatric surgery, that it is a teamwork. It is a team sport. So one cannot. It is not a one-man show. The pediatric surgeon cannot stand alone. So in order to operate properly, pediatric surgeon need a team of anesthetists, pediatric nurses, neonatologists. We have to collaborate effectively with pediatric pathologists, intensivists, and etc. This multidisciplinary approach will lead to improvement in care and outcome. Speaking about our children, once the child is planned for surgery, here we are not just treating the child. We have to know that we are treating the family as a whole. We are treating both the child and the family. So the perioperative counseling and preparation, and also intraoperative for our children, we have to consider these physiologic and anatomical things, to consider it in the positioning of the child, and warming devices in theater. Post-operatively, also considering this distinct physiology that we have been speaking about, we have to consider adjustment of the post-operative pain management and fluid management. Okay, now I would like to speak a little, although it is a very heterogeneous domain for the spectrum for cases that are managed by the pediatric surgeon. So I've chosen a little representative of age system to give a clue about the trajectory of pediatric surgery. So the pediatric surgery manages a diverse range of conditions, from congenital anomalies to trauma, oncology, each requiring specialized setting, specialized context, and specialized approach, and of course multidisciplinary team working. The fascinating thing in pediatric surgery is that our journey starts even before birth. So we are, and this is an area that is now evolving in pediatric surgery, that the fetal surgery, conducting some operation in the fetus while in utero, while it's still in the womb, to treat or mitigate the risk, the life-threatening risk of major congenital anomalies. Another area that is of significant impact and importance in pediatric surgery, that the neonatal bowel obstruction. So they usually present at the neonatal period with the spectrum of presentation ranging from atresia, malrotation, necrotizing enterocolitis, and etc. Each requires timely diagnosis and timely intervention. Okay. One of these GI presentation is intestinal atresia. When we say atresia, because we are going to pass through it multiple times through the presentation, is atresia is a blockage. It's a blockage of a canal. So as we know, the bowel is a tube. Here the picture on the upper left. In atresia means loss of that patency of the tube. So there is a blockage somewhere in the bowel, and so we call it atresia. So the proximal part will be dilated, as seen in this diagram, and the distal part to this atresia will be collapsed, as also seen here. Managing this patient usually present with as neonate with intestinal obstruction and abdominal distension. Failure to pass meconium requires timely resuscitation, because they are very neonates are very friable, and then after successful resuscitation, the role of surgeon comes in restoring the patency of this colon, as we see down here in this diagram, excising that atretic part and suturing the patent part to the patent part again. Another area is the malrotation. One of the common presentation in neonatal intestinal obstruction. The neonate present with feature of intestinal obstruction, with bilious vomiting. They rarely present with abdominal distension. And here, as we mentioned in the beginning of the presentation, this entity was discovered by Dr. William Ladd. So the operation carries his synonym, his name, up to date. And when we say rotation is twisting of this colon. So in utero, this intestine because the abdominal cavity lag behind the growth of the abdominal cavity, lag behind the accelerated growth of intestine. So the intestine has to leave the abdominal cavity outside, and then later to come inside with rotation with angle, in a total of 270 degrees. Then this defective rotation resulted in this twisting, as we see here, this knot, the picture in the middle. The role of surgeon come in this Ladd procedure, de-twisting this colon and restoring, removing the bands, and we do, as part of the operation, we do appendicectomy, because the malrotation will remain there. But this is detailing, is not in the objective of this presentation. Another common presentation in neonatal congenital anomalies is abdominal wall defect. When we say abdominal wall defects, from the name, it's like the abdominal wall is not well developed due to a complex developmental sequelae of events. So resulting in this bowel being outside, as we see in the pictures, either covered or uncovered. The first one is gastroschisis, the uncovered one. The covered one with a membrane is called omphalocele. These operations required, this condition required timely resuscitation and later decision on the operative, on the surgical repair, either because per se here the abdominal cavity is smaller to accommodate all this eviscerated intestine, so it can be with primary reconstruction and repair of the abdominal wall, or the surgeon can decide to institute, if the situation doesn't permit, can decide to institute a SiloBAC, as we see in the picture on the right side. So sometimes, and this of course, the patient will be admitted to the neonatal intensive care unit with the help of the multidisciplinary team, as we mentioned, as we stated earlier. Atrevia again, the same sequelae of event as it happened down there in the intestine can happen in the esophagus up there. If you can follow here in this diagram, you can see the esophagus is supposed to be a continuous tube, but down here there is an area with incontinuous area of the esophageal tube. So the baby presented, it shows up earlier with choking, excessive salivation, and in a trial to pass a tube, the surgeon faced resistance or difficulty in passing the tube in. Sequelae of, we do number of investigations before a resuscitative measures, and then the management is again surgery, opening the chest and suturing the esophagus together. With sometimes there is a lot of setbacks in the operation. This gap can be long, require also special surgical techniques. Another entity is congenital diaphragmatic hernia. When we say the diaphragm is the membrane separating the abdominal cavity from the thoracic cavity, and when we say hernia, when there is a connection between two visceral cavities. Okay, as you can see here in the X-ray, and that is quite abnormal to see the bowel loops in the chest, on the left side of the chest, due to the defect in the diaphragm down there on the left side of the diaphragm. These patients usually present with severe respiratory distress, underdeveloped lung, and scaphoid abdomen, of course, because the majority of bowel is up there in the chest. And the treatment require multidisciplinary team and the patient with intervention sometimes to help the respiration of the patient. And after adjustment of all these measures comes the role of the pediatric surgeon to close this defect in the diaphragm. Okay, another presentation down there in the colon. When speaking about congenital colonic obstruction, one should mention also the anorectal malformation, which for a long time, for decades, scholars used to call it as imperforate anus, but it has shown to be rather complex than being just an impatent anus there. So it is a spectrum of malformations, being and surprisingly sometimes we have the anus there, but still it is in abnormal place, or the rectum, as you can see here in this X-rays with contrast. In pediatric surgery we used contrast in diagnosing a lot of malformations. So instilling this contrast through the colon through a stoma, of course, created, as we will see later, then shows this connection between the pouch of the colon urinary system. So this require multidisciplinary team as well, and surgery to control this fistula if present, and to do the anoplasty to create the anus. Hirschsprung disease, something I was telling my colleagues few weeks ago that because we face quite considerable number of Hirschsprung patients. Now I have like 2 patients under my follow-up currently, awaiting their surgery. So Hirschsprung disease is a particular entity in pediatric colorectal surgery, and it is basically this colon down there in the area of the rectum and the sigmoid lacks neurons, lacks neuronal tissues, which help in the peristalsis, which is the pushing force for the luminal content. So this distal colon lacks the movement required to expel this content outside. The operation for this disease called pull-through, but before that it is a disease that is managed by stage surgery, mostly, with new advances now introducing single stage surgery, and requires a multidisciplinary team of pathologists, because we start with taking a biopsy, we're taking sample from the rectum of this child to prove that there is no neuronal tissues there, and then came the planning and of the pull-through by resecting this bowel that doesn't have nails outside. It is a distinct area in pediatric surgery because it is not just about it is a functional problem. So here the follow-up for Hirschsprung and for patients with anorectal malformation is usually a lifelong follow-up, because the sequelae, the functional outcome are not confined just to the structural problems that end up with resection of the aganglionic segment or creating that anus, as we are going to see later. I hope I'm not giving much so far, but we still have little to add. I hope that people are still on board with me. So coming down the line, we have to speak a little about pediatric trauma, and being the leading cause of death and disability in children, injury and accident, road traffic accident, domestic trauma. Children are not separate from conflicts, and also being involved in this war conflicts and injuries. And for example, now my home country, Sudan, is suffering from this devastating war, and my colleagues, they are doing great work regarding managing children with trauma. Managing children with trauma required, of course, team-based approach, required context that is ready to receive patients with trauma, because as we know, managing trauma is complex and demanding. So preparing this system-based approach for trauma improve outcome. There are some unique challenges in managing children with trauma that, as we mentioned earlier, there are anatomic differences. So children have big head size in proportional to the whole body size, and also they have pliable skeleton, which makes them more prone to trauma, and also their physiologic response. So children in trauma are very deceiving. The child, you can see the child It's very compensating, very clinically stable, but the moment they start decompensating, it accelerates fast, and usually it is very devastating with catastrophic sequelae. And also, in managing children with trauma, one should consider the developmental consideration that you are managing a child, so you are managing a hope of a nation, that it is any disability will lead to disabled individual that is not able to produce to the family, to the country, and to live with dignity. In trauma, the management generally follows the general scheme of managing trauma, the ABCD approach, with special tailoring to pediatric patients, with in consideration for this physiologic, psychological, developmental domain that we have mentioned earlier. So the goal is to optimize the care all through the continuum. The managing a child with trauma start long before arrival to the hospital. So it starts at the site of trauma with the initial measures to minimize the sequelae and the second hit trauma, the things, and then continue through the continuum to the pre-hospital care, emergency department, all through the rehabilitation after completion of management. So we have to have the right place ready to receive this patient, and the right setting for timely management of trauma patients. Other emergencies in pediatric are foreign bodies, and I guess most of the floor has encountered such things with children, of course, especially toddlers. This age group between 1 and 3 years are playful, and usually they are prone to ingestion of even solid items, solid food can cause airways or upper GI obstruction, as we can see here in this aerogram, in this X-ray. There is an object, probably a coin, that is indulged here in the esophagus of the patient, and also here another one in the stomach of the patient. In the other graph, this requires rapid protocols for managing the life-threatening sequelae. Usually at the ER setting, as a multidisciplinary team, the role of pediatric surgeon come to intervene to remove these foreign bodies, either with endoscopic measures or with the laparotomies or operative management sometimes. Another alarming presentation, emergency presentation, is incarcerated hernia. When we say incarcerated, that hernia is, as we mentioned earlier, when an organ or a viscera traverse from a cavity to another. So in children we have the hernia. The hernia is unique because it is developmental. We have what we so-called the processus vaginalis, connecting the abdominal cavity to the scrotum. Here in children it remains open. It's supposed to close at birth, but here it remains open, leading to hernia. Sometimes hernia can present as emergency with incarcerated, which is able to reduce back, blocked hernia, as we say, with consequences on the bowel inside there, and then mandate emergency surgical management. Something worth mentioning also, the testicular torsion. Testicular torsion, when we say torsion is a twist. So as we see in the diagram down here, we have the testis, and it has a pedicle that carries the blood supply to the testis. When we speak about torsion, it means the twist of this pedicle. So when you twist something, you imagine you are twisting a tube, so the content cannot traverse through this tube. So this is exactly what happened here. Then the cutoff of blood supply from the testes predispose these testes to ischemia and necrosis that mandate emergency and timely surgical intervention to untwist this torsion within limited time, because we have the rhetoric that says time is tested, so it can't survive for more than 6 hours, which we so call the warm ischemia. So given this, any child presented with pain in the groin, in the scrotum, nausea and vomiting, this should be taken seriously, and the patient must be presented to the area facility with the pediatric surgery service to explore these testes within 6 hours of the onset of symptoms to salvage these testes. Unfortunately, here in the setting of the LMIC, still the awareness of the community and these things are not that to the appropriate level. So we usually see them late, and unfortunately sometimes with lost testes ended up with orchidectomy, taking this dead testicle out. Okay, some presentations that I think the floor are familiar with is acute appendicitis when the child presents with abdominal pain. The appendix is small, as you see here in this diagram, the area with the circle. This is the appendix. So sometimes it gets inflamed, what we so-call acute appendicitis with the patient. The child presents with acute abdominal pain, nausea, vomiting, and sometimes diarrhea with a spectrum of presentation, but mainly the pain, the shifting pain. So requires resuscitation and emergency surgical intervention to remove this appendix. Another GI emergencies, if an infant is presenting with vomiting, projectile, what we call projectile vomiting, so explosive vomiting. The vomiting is coming like forceful. Sometimes you have, as we see here in the diagram, the stomach, the pylorus. The pylorus is the exit area of the stomach. So sometimes some children in this area get hypertrophied, get enlarged for complex etiologies, the developmental, genetic, and some environmental factors. At the end, the management is widening this pylorus in what we so-call pyloromyotomy. Something worth mentioning also in GI emergencies is intussusception. Intussusception means, as you can see in the diagram here in the left upper part, the colon or the bowel is getting invaginated into the adjacent bowel, like the bowel is entering into each other. So we call it intussusception. It's common between the age 3 months to 3 years in toddlers, an infant and toddler. And we do ultrasound, as you can see down here. We call it target sign. So target is like if you are shooting on a target, it's very prominent features or shape that easily detected usually by the radiologist. The management after resuscitating the child can be non-operative and with reduction. We introduce a tube inside the rectum and we push with monitoring either air or fluid in a trial to reduce this bowel from each other. This area is a good presentation to the concept of non-operative management in pediatric surgery. Not all pediatric surgery patients or presentations not always we rush to theater, and then sometimes we try some less invasive approach to manage the patient, and this is one good example for such. But sometimes, of course, they need operative management if the child has feature of peritonitis, the abdomen is or the delayed presentation more than 3 days. We go and open the abdomen to treat it. Another system also, because as I told you earlier, it is of great difficulty to cover all pediatric surgery in the session, but I tried to put a snippet for the audience from each system or each presentation, at least to spread the word around, to raise awareness, because especially the emergency presentations, they are vast, they are heterogeneous, they need some early detection, so it facilitates for us the management. And then another area of importance is the genitourinary area. Some presentations like hernia, as we mentioned earlier, this picture on the left upper, and cryptorchidism, and the other name we call undescended testis. Normally the testis in the fetus develop in the abdominal cavity, and then it descends as the child is growing. For some reason, the testis can be hanged up there, either in the abdominal cavity or along the way of descent in the groin, the upper scrotum. So through orchidopexy, we have to bring these testes down. Another picture is showing hypospadias, another epispadias, when the urethra is underdeveloped and the opening of the urethral meatus is not at the tip of the glands. And all this, then picture showing bladder extrophy, all this complex, all this urinary developmental and congenital anomalies require teamwork, require stage surgery and reconstructive approach and skilled surgeon. This is why now, as part of the development and evolution of pediatric surgery, now we have this subspecialties. So we have pediatric urologists, and they are doing great reconstruction, restoring the anatomical and functional abilities for these patients. In the trajectory of the head and neck, our presentations are usually developmental track. When we say developmental, we mean something that was supposed to disappear after birth, but it continues to some reason or another through a complex etiologic factors to continue with the patient. As we see up here in this picture, this cyst in the midline, the anterior aspect of the neck, what we so-call thyroglossal cyst. So it's like the remnant of the descent of the development of the thyroid gland. So it remains a canal or a duct or a tract connecting the thyroid here to the base of the tongue. So and then the picture down here, the branchial cyst from the branchial cleft.
Excuse me, Dr. Hani.
Yes.
Hello, Dr. Hani.
Yes.
Please, because of our time, we are running out of time. Please, we'll just have 2 minutes more, please.
Okay. Let me now, for the sake of time, just have a little of touch on other areas. In pediatric surgery, also we are dealing with tumors, but our tumors have distinct biology, distinct etiologic factor, distinct genetics, and usually of embryologic origin. That cells continue with the fetus after birth and continue growing leading to tumors, blastomas, teratomas, and etc. That requires multidisciplinary team for their management. Another one of the concepts in pediatric surgery is stage surgery. For sometimes, because the physiology of the patient doesn't permit doing all the reconstruction or the repair in one session, so sometimes we need to do surgery in stages. Major things like if we have big omphalocele in rectal malformation, we do, you see down here the stoma, and then we do the repair down there in the anus, and then later we come and close this stoma. Then sometimes in pediatric surgery, we don't just do corrective surgery. Sometimes we have life-enhancing surgeries to improve the quality of life of the patient, not exactly to correct an anomaly. For example, this continent catheterizable channels, Mitrofanov procedures, when the child, for example, has urine incontinence, so we use the appendix to connect the bladder to the skin outside. By doing so, we create a channel that the patient can, by himself, put the catheter to empty the bladder in a timely manner, like every 3 or 4 hours, and to achieve continence and live with dignity. And also the same applied for the colon. In children, our management continues through life, so we have to do transition of care after reaching adolescent. We have, especially children with Hirschsprung and rectal malformation, we have to transmit this patient from pediatric health system to adult health system through specialized clinic liaison by a transition nurse. So despite all we have mentioned in the presentation today, we are still facing a lot of challenges and consideration in pediatric surgery, given that 66% of where children lack access to surgical care and the vast majority of this lies in LMICs, low and middle income countries. So and through global initiative, we hope that this gap will be bridged, and this is a call for action for all of us to advocate for protocols that are adjusted to pediatric patients, and to ensure that every child, regardless where they are born, they have access to safe and timely surgical care. Takeaways and conclusions. In conclusions, that we spoke about children being a distinct entity from adult, and we discussed their distinct physiology and anatomy and special consideration, and also we mentioned some areas in pediatric surgeries and some concepts that are particular to the specialty of pediatric surgery, like stage procedure, quality of life procedures, transition of care, and the global disparities that are there in pediatric surgery care. Something to end up the meeting with is that pediatric surgery for the coming generation of doctors, that pediatric surgery is a rewarding and vital field that treat heterogeneous presentations and anomalies, and prevent disabilities and restore dignity of the patient. So we have to work together to ensure that to bridge the gap, the global gap in pediatric surgery service. Thank you for your for your attention, and now the floor is open for discussions.
Okay, thank you so much, Dr. Hani and Professor Omokhoa. Thank you so much for this wonderful, impactful section. That was so great, and it was so inspiring. So because of our time, about our question and answer, we'll just take one question from the chat box. And the question goes to you, Dr. Hani. The question is, what's the difference between toxin and viral cell? What is the
Sorry,
difference
between.
between toxin and varicocele? Can you hear me?
Yes, but the difference between what? Sorry.
Yes, toxin and varicocele from the chat box. So that's the question.
Okay. So when we say corrosive, something corrosive is something that is burning, like acids and alkali. The main components, either acid or alkali, and both cause damage to the mucosa of the esophagus or and the subsequent bowel. So toxins are either drugs, either any other chemical. But when we say corrosive, it's something that is burning, that is eating through the wall of this GI tract.
Okay, thank you so much. Thank you so much. So right now we'll go into give our closing remark. But before our closing remark, we'll like to introduce our team for the month of June. Our team member for the month of June. So it's a great privilege to honor. It is my great privilege to honor and announce the TRG team member of the month for June 2026, Professor Dr. Bhavinath Bahara. Professor Dr. Bahara served as the TRG Girls Faculty Lead for Surgical Innovation and Minimal Invasive Education. Through his dedication, leadership, unwavering commitment to mentoring, passion for education and innovation vision, he has made remarkable contributions to advancing surgical education across the globe. Professor Dr. Bahara, on behalf of the Operating Room Global Education and Training Community, we sincerely thank you for your dedication, excellence, and the lasting impact you continue to make within our global community. Your work inspires countless healthcare professionals, and we are truly grateful for your service. Congratulations once again on this well-deserved recognition. Everyone, let's join in giving him a visual applause. Thank you. So going into our closing remark, so on behalf of the Operating Room Global, we would like to sincerely thank our speakers for their valuable insights and our participants for joining us from across different countries, time zones, and professional backgrounds. We recognize that many of you are participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and preoperative care in your local setting. Please feel free to share key lessons from today's section within your team, institutions, and professional network as part of strengthening safe and effective practice globally. We encourage you to stay connected with TRG through our upcoming webinars, training programs, and research activities, which are published in our website and across our official platform. To receive your TRG accredited training certificate, please note the following. Immediately after this section, the evaluation and certification form will open in the browser on your device and remain active for 24 hours only. Certificates are issued within 5 to 7 working days after successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TRG membership ID. Once again, thank you for being part of TRG Global Community. We wish you a safe, productive day or evening ahead, wherever you are joining from. Thank you once again for joining us. We look forward to supporting your continued professional development with the Operating Room Global. Thank you so much, everyone, and we'll end the webinar now.